So, welcome back. This is second part of lecture on vaginal birth after cesarean section trial. What are the contraindications? In which conditions, situations, women should not be offered to have a trial of VBAC? First is if there is previous history of having a uterine rupture. Okay. Second is if previously the woman or the records show us that her discharge slip or the hospital record shows us that she previously had a classical cesarean section. What do we mean by classical cesarean section? That it was in the not in the lower uterine segment, but in fact it was in the upper part vertically. Okay, so there are because very high chances of having a uterine rupture, so it's contraindicated, absolutely contraindicated. Then in women who have other absolute contraindications to vaginal birth that apply irrespective of the presence or absence of a scar. For example, if it's a major anterior placenta previa, major placenta previa, then of course she should have a C-section, right, rather than having a trial of VBAC. And then previous uterine surgery where uterine cavity is opened. What do we mean by that? So, for example, if a patient had large intramural fibroids and maybe they had also the submucosal component. So, while removing the intramural fibroid, the doctor had to open the endometrium. Okay, so how do we know about this? By reviewing their previous discharge notes or their hospital record. Okay, a lot of women they have a history of myomectomy, but they don't know, right? It might have been performed in other countries. So in that case, it's important to raise to just consider it like if the cavity has been breached or opened. Why? What is the main risk of attempting a vaginal VBAC? It's basically uterine rupture. And when there is uterine rupture, of course, the baby can escape from the uterus into the abdominal cavity, right? And become hypoxic. So it's a life threatening condition not only for the baby but also for the mother, because if this tear is extended, it can extend anywhere, right? Especially if it extends toward these very huge blood vessels, uterine blood vessels in the broad ligament. So it's very next, right? So uterine vascularity is very increased. So if it extends towards the broad ligament, that that can cause the life-threatening situation for the mother as well. So in general, the lower segment, lower transverse cesarean section is performed. Remember, we are not talking about the skin incision. Okay, so skin incision, yes, it does matter, especially for cosmetic reasons. But from a doctor's point of view, what is more important is to know what was the type of incision on the uterus. Okay, because you may notice that a lot of women from the Philippines, I don't know, for some reason, they give vertical incisions on the skin, but inside they perform lower uterine segments C-sections. I don't know why, but you will find because in the UAE we see a lot of Filipino patients, so you will notice that you will. I'm sure you will come across such a patient. Then, what are the factors which can increase the risk of uterine rupture during VBAC? It's first is the short inter pregnancy or inter delivery interval. So ideally, it should be at least 18 months. Okay. Secondly is it's a post-age pregnancy. Okay. Third is age, advanced maternal age. Next is increased BMI. Next is, now I know that you understand Bishop score. So if the Bishop score is poor, okay, that means it's unfavorable cervix, so it's less likely to dilate or even efface. And if it's a big baby, macrosomic baby. And how can we know on ultrasound? So if we measure the lower uterine segment where the incision was given, that thickness, right? If that thickness is very thin, actually it's thin and not thick, that means that there are increased chances of having a rupture. So whenever there is a woman with previous history of a C-section, to deliver her we have two options, right? Either give her a trial of VBAC or just perform an elective repeat cesarean section. So this term, that specific ERCS, means Elective repeat cesarean section, which means it's an elective procedure or a planned procedure. Okay, and we are doing a C-section. So, what is the success rate if a woman does not had any contraindications? What is the possible success rate? So, research shows that it's after one C-section, it's 72 to actually 76%. So, in other terms, we can tell a patient that if there is no contraindication, okay. So, 3 out of 4 patients can deliver vaginally after having a C-section. Okay. And what is the single best predictor of a successful VBAC? It's previous delivery, especially previous VBAC. So that means, say, for example, if a patient she's now is having her third pregnancy, first was a C-section, second was a VBAC, and now in this pregnancy, her chances of having a VBAC are even more than this 72 to 76%. It can be even up to 90% because previously she has delivered a baby vaginally and especially after a C-section. So even this success rate is even, it's still there. Say, for example, the same woman, if her first pregnancy was delivered by a vaginal birth, then second was a C-section, still it will be high. Okay. So it also depends on what was the previous indication of her previous C-section. Do you remember when we take history, we take a very detailed obstetric history, right? Past obstetric history. When was the C-section performed? At what gestational age it was performed? Why was it performed? Were there any antenatal, intrapartum, or postpartum complications? Because all of these are clinically important, especially why was that C-section performed, because it can affect the success rate of a future VBAC. Okay, so for example, if it was a future male presentation, for example, if the first C-section was performed for a breech baby, right, then the chances of having a VBAC they are even higher, 84%, compared with women who had a previous C-section for either labor dystocia, means the cervix did not dilate. It's called poor progress of labor. We have a separate lecture, but like, so if because this labor dystocia can happen again, or fetal distress. Okay, so compared to fetal malpresentation, these you do not need to remember these figures 84, 64, and 73, but it's good if you understand this 72 to 76%. Remember this. Okay, now we will discuss the benefits of a planned VBAC and benefits and risks, okay, for the mother, and then in the next slide for the baby. So for the mother, for a planned VBAC, yes, there are high chances. 72 to 3 out of 4 women can deliver vaginally. Okay, vaginal birth is always good for the mother. Okay, so it's less morbidity. There is quick recovery, shorter hospital stay. Okay, but vaginal birth in for the baby it's slightly more riskier compared to a C-section because baby has to bear the contractions. Okay. So approximately 0.5% risk of uterine scar rupture. That means one out of 200 there are chances of having a scar rupture. And but it also depends on other factors, right? What is the obesity? What is the other things? Okay. So, and if that happens, that can be life-threatening. Increased likelihood of future vaginal birth. Once she delivers normally, there are increased chances. But with vaginal birth, what can happen in the end? We may need to even apply a forceps or vacuum, or even if the baby is born without instrumental delivery, then the woman is at increased risk of having perineal tears. Okay, like third degree tear, fourth degree tear. And of course, what matters is birth weight of the baby because the bigger is the size of the baby, the more chances of having perineal tears. And the risk of maternal death is small, but yes, well, it can happen with any procedure, right? Even with the pendectomy. So, compared to a C-section, the risk of maternal death it's small, but it's not zero. Now, whenever we have to do a repeat C-section, it's planned C-section. It's performed before EDD. It's definitely performed before 40th week. Okay, and it depends on the growth of the baby. A lot of factors, right? Some women can even have an elective repeat C-section even preterm. So in general, if there are no complications, it's best performed at 39 weeks. Okay, and if the patient is not diabetic and if there are no growth concerns. So what is the benefit of having an elective repeat c-section? The patient can plan, especially if there are working women, their families can plan it, they can take leaves. It almost avoids the risk of uterine rupture because the uterus is not contracted. Okay, contracting reduces the risk of pelvic organ prolapse and urinary incontinence, enhancing compared with the number of vaginal births. Because if a woman has especially repeat vaginal births, in future she is at risk of having pelvic organ prolapse, right? So C-section reduces that risk. Longer recovery, yeah, but the problem is it takes long. Okay, so it's more painful. It's longer recovery. Option for sterilization if fertility is not longer desired. Yeah, that's another benefit, that women can have tubal ligation or self-injectomy. Okay, nowadays it's self-injectomy is performed for as a method of permanent sterilization. Okay, so and future pregnancies likely to require cesarean delivery, increased risk of placenta previa, creta, and adhesions with successive cesarean deliveries and abdominal surgery. And of course, there is risk of maternal death, which is of course more compared to having a VBAC. Okay, so actually, yeah, if it's a successful VBAC, I'm talking about successful VBAC. Okay, but of course, if things go wrong, then there is more risk with the VBAC. Okay, so the rest of the lecture I'll do in the next part.